Hello, my name is Olivia Catalano, and I'm the Reproductive Health Program Manager at Finger Lakes Community Health. My pronouns are she, her, and hers.
And hello, my name is also Olivia, and my last name is Clinton, and my pronouns are she, her, and hers, and I am the health advocate for Yates and Steuben County.
So, if you're not familiar with Finger Lakes Community Health, we are a federally qualified health center located all around the Finger Lakes, and we provide a variety of services. Those services include medical and dental, mental health care, nutrition, reproductive health, and support services. So, support services include things like transportation, insurance enrollment, language assistance, and navigation of the system. So, today we're here to talk about cultural competency and sexual health. And so this workshop is going to focus on what cultural competency is and the needs of different generations. We're going to talk about how those working with diverse populations can incorporate cultural competency related to sexual health in the care that they're providing. We'll provide you some tools to communicate and work with various groups. And you're going to leave understanding why cultural competency impacts your decisions to seek medical care and how we can better serve our communities. So, some guidelines for this session, even though we're in a virtual world, we encourage you to participate, turn on your camera, see one another, and smile. This is a safe space, and we're all learning together. So, as the famous phrase goes in sexual health, don't yuck my yum. So, if you disagree with something that I like, there's no need to publicly shame or share your distaste. However, looking at things in a cultural competency lens, everyone is a little different, right? So we learn together and our path together is forward. So feel free to share in a respectful manner as we go through today.
All right, let's get started. So, who do you work with? Do you work with boomers who were born in the mid 40s to the mid 60s, or Generation X, which picks up from the mid 60s to the early 80s? And then there's millennials, also known as Generation Y, which are those born 1982 to the early 2000s. And lastly, there's the youngest group in the workforce, which is Generation Z. And this is the first time in history that four generations are working together in the same jobs. Workplaces are changing, the competition is intense, and the composition is changing as well. There are more women, people of color, and immigrants in the workforce than ever before. And this means our groups have various needs and respond to various conditions. In each category, you can see some characteristics of the groups described. Boomers are self assured, competitive, goal centric, and disciplined. Generation X is balanced, unimpressed with authority. They're technologically adept, they're flexible, and they value work and life balances. And then millennials are ambitious, they're relaxed, they're tech savvy, and they want higher pay for less work. They crave attention and they job hop. Lastly, there is Generation Z, which is competitive, motivated by security, they're independent, and they want to be catered to. It is important to remember that this does not mean everyone in these groups will meet every one of these descriptors. They're just general findings. And then lastly, be aware that behaviors inside the workplace, as if these people were your coworkers, these behaviors translate to care and education that people would like to receive.
So let's look at really now what is cultural competency. Cultural competency is understanding and appropriately responding to the unique combinations of cultural variables and a full range of dimensions of diversity that professional or clients or patients or families bring to interactions. So, since we're specifically focusing today on cultural competency related to sexual health, I delved a little bit further into this and went to the American Sexual Health Association for their definition. So, they define this as culture and cultural diversity can incorporate a variety of factors, including but not limited to age, disability, ethnicity, gender identity, which includes things like gender expression, national origin, which include things like ancestry, culture, language, dialect, citizenship and immigration status, and race, religion, sex, sexual orientation, and veteran status. Linguistic diversity can accompany cultural diversity. So why is it important for us to understand cultural competency, cultural diversity, and relate this to sexual health? So cultural competence in service delivery allows us to provide increasingly important services to those we serve. It allows us to respond to demographic changes in the United States. Not everyone looks the same way or acts the same way as we do. It allows us to eliminate long-standing disparities in the health status of people based upon racial, ethnic, and cultural backgrounds, and improve quality of services and health outcomes, and of course, meet legislative, regulatory, and accreditation mandates that are coming out.
All right, so welcome to our first activity. I'm going to say a word, and I'd like you to think to yourself or write in the chat the first thought that comes to your mind. There's no right or wrong answer, but this will be important to help us understand any bias we may have, good or bad, towards a certain group. This is important in understanding how we may work with this group or what may be barriers they face. Let's start. Disabled, teacher, police officer, elderly, women, men, language, LGBTQ+, African Americans, and whites. Okay, done.
So some words we would have expected you to potentially come up with here. For teachers, you could be thinking about kind, focused, or even educators.
Yes. And then for elderly, you could see the words like grumpy or slow. For women, you could see gentle, talkative, or caring. For men, maybe you saw brave, aggressive, or helpful, more masculine terms. And maybe for LGBTQ plus, you saw outgoing or colorful or dramatic or eccentric even.
So with the awareness from our activity, we want to now examine our CLAS standards. So it's important to be aware of the various groups that we may interact with and the preconceived notions that we have about those groups, because that may impact our ability to work with them. We want to be aware of any bias, internal or otherwise, as we are working with various groups so that we can overcome them or look for ways to better serve our populations. So the CLAS standards, these are national standards for culturally and linguistically appropriate services, which aim to improve healthcare quality and advance health outcomes. So the goal, as you see here, is really to provide effective, equitable, understanding, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. So you see here on this brightly colored wheel, we have all of the things that make up someone's culture, or some examples of what make up someone's culture. So do we speak the same language? What language do they speak as their preferred language? What are their rituals or customs within their culture? What are their beliefs? What are the foods that they like to eat? All of these different pieces make up someone's culture and impacts how they are perceived by others. So we see here with our CLAS standards, we can use these to provide culturally competent care. And why is it important? It allows us to provide equitable services. Equitable being fair and impartial. So everyone comes to us in life with different paths, people's struggles look a little different, and some can be a lot more obvious than others. However, we can't ask people to just disclose what things they've experienced in their lives. So, being educated on different cultures and certain things that they may have experienced allows us to provide better quality care to them. So, this takes into account the cultural beliefs, preferred languages, what their health literacy level is. So, if we're speaking at a level that is far above where their education or reading comprehension is, our patients are not going to be able to work well with us. And what is their communication needs? So one of the ways that we practice this at Finger Lakes Community Health is we use our patient navigators. They are in-person interpreters to live translate French and Haitian Creole and Spanish and the various pieces of Spanish, because not all Spanish is the same. We also use the language line and translators over the phone, but we prefer that in person because you get a better relationship building. So we know that using CLAS standards helps us make services that are respectful, understandable, effective, and equitable. So I like this picture here because this picture shows the difference between equality. Equality is everyone gets the same thing no matter what. Equity is trying to help everybody um, to be fair and impartial. However, in reality, we know that some people have other advantages in life that people would never dreamed of. Some people don't realize those advantages are in fact advantages. So we want to liberate everyone so that the services really truly can be equitable, fair, and impartial, and everyone has the same opportunity and can leave with the same outcome.
All right, so what are the three C's? The first is communication, and then cultural competency, and then customer service. When you are responding to concerns, know if it is a cultural misunderstanding. Make sure to provide an open dialogue, and then provide resources such as anonymous hotlines, human resources, or a supervisor who could help. Having a cultural competence. And then lastly, if there is an uncomfortable situation, make sure to have resources you can turn to, like a compliance hotline, trainings, and then always feel free to ask questions.
So now we move more into cultural competency and sexual health. So let's look at it from social determinants of health and how this impacts our customer service side of cultural competency that Olivia just mentioned. So the support services that we offer at our agency, these are non-clinical services that assist with navigation and barriers associated with social determinants of health. Many are free, right? So socioeconomic factors, we see things like education, job status, family support, income, or are they safe in their community? The physical environment where they actually live. We know that 50% of your health outcomes can be traced to your zip code, and that's a pretty significant thing for us to be talking about. So when we think about cultures and races all living in the same area or socioeconomic statuses living together, we have to think about, is there lead painting in that area? Is there a um, recycling plant nearby for batteries, which may be potentially leaking things into the community? Are the gas stations up to code? All of those physical, environmental pieces actually matter. Then we have health behaviors, as mentioned. So, tobacco use, diet, exercise, alcohol, sexual activity, and then, of course, the health care that you receive. So, it's really important as our nation rapidly changes, growing more diverse, and increasing with our cross cultural interactions, that we be aware of cultural competency because this is critical in reducing health disparities and improving access to high quality health care that includes awareness of social determinants of health. So, if we decide that we're not going to pay attention to this when providing sexual health care to someone, we're doing a disservice. We know various groups experience various health concerns at different rates. Diabetes, for instance, is one that can impact your sexual health. Studies have shown that Hispanics are more likely to develop diabetes than the general population, or even have undiagnosed or underdiagnosed than non-Hispanic whites or non-Hispanic blacks. Is that because they're Hispanic? No, right? Being Hispanic in itself doesn't make you more likely to develop a disease. What studies have shown is it's genetics. So For instance, food could be one contributor. So Hispanics eat food which is high in fat and calories. There's often big family celebrations, which may involve pressure to overeat. And even turning down food could be considered impolite in the Hispanic culture. Another factor could be someone's weight and activity, and that could play a role because weight is actually seen as a sign of health in some cultures. So being overweight would be considered a sign of being healthy. We know these pieces that are part of your social determinants of health, often addressed by support system: poverty, unemployment, unstable neighborhoods, unequal rates of incarceration, all contribute to unequal access to healthcare and a rise in a young person's risk of contracting HIV or STDs, or even being a teen parent or a young adult parent. So, research demonstrates that institutionalized homophobia results in high rates of violence towards LGBTQ youth and communities. So, if we're not looking at family support, education, community safety, all of these factors, we're really not doing justice when providing care to the populations we're trying to work with in a sexual health lens. So we found a wonderful resource through Advocates for Youth that was talking about important points when we're providing culturally competent care. The first one here is the impact of prejudice and discrimination. So, looking at a historical and cultural context of reproductive rights, we know that women of color and low income women is one where we see a lot of persistent inequality. That inequality in the healthcare system has resulted in communities having painful memories of abuse, along with anger, distrust, and suspicion of public health that a lot of people still experience today. So, some examples that we've seen of this in our history is by 1982, 24% of African American women, 35% of Puerto Rican women, and 42% of Native American women had been sterilized, compared to just 15% of white women. We have the history of the eugenics movement, the Tuskegee syphilis study, and recent efforts to restrict states from offering health services to immigrants, all reflect really racist and discriminatory policies in reproductive health. We also know that there have been efforts focused on distributing things like Norplant or Implanon into or Depo-Provera to low-income adolescents and welfare recipients. And that's not fair, right? We need to provide effective, equitable, equal services to people through that cultural competency lens. We know that there are other issues that are also being faced, right? So even in the 20th century, just this year, we saw the migrant women being sterilized without being properly educated or understanding the health literacy of the materials that they were signing and consenting to. That's not fair. Prejudice and discrimination have strongly negative impacts on the health and well-being of young people. So, for instance, African Americans suffer negative sexual health outcomes at greater disproportionate rates, with young women and young men who are sexually active being most at risk, of course. But the common misconception is that the young African Americans simply are just not as careful as whites. That's an awful misconception, right? So, studies have shown that even with equal or fewer sexual risk behavior, African Americans are actually more at risk. Why are they more at risk? It's not solely for the risk of their personal behavior, but also because of the function of the pool of disease already in their network, right? So they have higher distrust in the medical system. They are less likely to access care. They're more likely to wait until symptoms are more severe. So as a result, they have a higher risk pool. We know that Gleason had a report that came out in 2007 that talked about the experience of the LGBTQ group and surveyed over 6,000 middle and high school students and found 9 out of 10 students experienced harassment. That's pretty significant. We know that LGBTQ students are more likely to be homeless, and that impacts their ability to have those support systems that we talked in, a safe physical environment, the family support. We know that these prejudice and discrimination have an increasingly negative impact on the health of young people. And if we're not talking about this and aware of this, we are unable to properly serve them. We know that teens who experience prejudice and discrimination may have less self esteem and fewer resources and skills to meet the challenges that teens face. This is pretty significant because adolescence is full of many changes: physical, social, and cognitive, or even emotional changes. In fact, the human brain keeps developing until age 25. So we need to make sure that teens have positive role models and a sense that they belong. We know that young people face obstacles related to age. So, age based discrimination is evident in reproductive health programs. However, here in New York State, it's wonderful that at the age of 12, a youth can access sexual health services for free without parental consent, although we do encourage family involvement at the age of 12. However, some things that we still face with issues: HPV vaccine, for instance. A minor can consent to get that HPV vaccine, but it's going to go on their nicest record, which could then be printed for their parent, and then their parent would find out that they have it. Other barriers that we see include confidentiality, transportation, and payment. Lastly, we know that media is a really strong influence on our youth today and even adults. So, media often likes to present people that are young as problematic, often focusing on things like school failure, substance use, violence, pregnancy, and sexually transmitted infections. These cultural images that we see impact our behavior every day. This influences our beliefs and how we feel people fit or don't fit into a group. So we need to make sure that we have better role models across all communities.
All right. So, how can you assess the needs of those you work with? And assessing the health status of youth and the accessibility of services can be done by getting community data like age, gender, race and ethnicity, family income, health, education, and economic factors. As assess the cultural appropriateness of services, and then plan your program or outreach or delivery with the awareness of cultural competency of your staff. Train staff to do activities to keep awareness levels up and have an open environment. Don't assume you know. If someone speaks, listen to them, and then learn about cultural and familial backgrounds, health beliefs, and religious practices of each young person in the program. Understand that these things impact their knowledge, communication, relationships, contraception, and childbearing. Tailoring education for this increases your effectiveness. Assess the experience and knowledge of youth in your community by focusing on the trends in the data to help those you serve. You could use surveys, you could use focus groups, and you could really meet the people to figure out how to best serve them. Meeting people one-on-one or online or through surveys or in their workplace hangout even could work.
So we really want to empower youth and offer culturally competent programs in the community. So how do we do that? We can support peer education and the leadership of youth. So we empower youth to offer culturally competent programs in their community. Do this by using our approved curriculums, right? So in this picture here, this is one of the groups that we run called REAL. So REAL stands for Responsible for Every Action in Life. And what we do is we work with groups of students for 6 to 12 weeks, and we cover many topics like communication, body image, contraception, sexuality, LGBTQ. We use various learning styles and interactive lessons to work with these youth. And then at the end, they actually get a grade by teaching one of the lessons back to the group that we've already taught. And what they do is they put a spin on that. So they get a grade from the teacher for completing this program with us. They learn, they get to develop a lesson based upon a guideline. And then they can then share that information with others outside of the room too. So the picture that we have here is them participating in our Thanks Birth Control campaign, which hopefully you know about, Thanks Birth Control Day, that happens each year in November. And they picked these statements from the campaign and they drew them on the board, or they did something fun and creative with them, snapped a picture, and then shared them on their social media. So that was their peer education, how they wanted to be involved. We created opportunities for youth to talk about openly and about racism, sexism, homophobia, class discrimination, and other forms of oppression. They may not have an avenue anywhere else to do this. So, part of being that whole askable, trusted adult is when someone wants to talk about something, let them talk, listen, let them share their experience, try to learn with them and grow with them. Replicate and adapt HIV and STI and pregnancy prevention programs that have been evaluated and shown to achieve positive outcomes for young people, right? Across the board. We want to help them. We want their feedback. We want to know what works, what doesn't work, what do they want to see. And then lastly, ensure that prevention efforts are culturally specific. So, for example, if I'm working with a private school group of Catholic students and I'm talking to them about using birth control to prevent pregnancy, that's not really culturally competent for their religion, right? Catholics really base a lot of wait until marriage to have sex. And you shouldn't have premarital sex. So, if I want to better appeal to that group, then I should be talking to them about abstinence as the best method and how to know when you're ready to have sex in your marriage and what's the social and emotional and physical things that also happen with sex. But if you would like to use contraception or birth control to help with your period regulation or help decrease your risk of cancer, these are the options that you can potentially utilize. That would be a better culturally specific um, avenue for me to do contraceptive education with.
All right, so here's our second activity of today. It's similar to Cross the Line if you've ever done that. This is just the COVID adaptation for our Zoom meeting. So there is no pressure to respond to any of these. Exercise the option to pass if you wish at any point. And then please be respectful of one another and remember this is a safe space. It's important to be as honest as you can be, yet don't risk more than you are comfortable sharing. Okay, ready? Here we go. Raise your hand if you are female. Raise your hand if you are male. Raise your hand if you are left-handed. Raise your hand if you grew up in a large city or town. Raise your hand if you've watched a Halloween-themed movie in the past 2 weeks. Raise your hand if you've been outside of the US in the past year. Raise your hand if your parents are divorced or separated. Raise your hand if you practice a religion. Raise your hand if you are atheist or agnostic. Raise your hand if you know someone who is personally tested HIV positive. And raise your hand if you know someone who has died from AIDS. Raise your hand if you or a family member has a terminal illness. Raise your hand if you have participated in a racial, sexual, or cultural joke. Yeah. Raise your hand if you don't like these jokes, but you don't do anything to stop them. And then raise your hand if you consider yourself a feminist. And then raise your hand if you are comfortable with homosexuality. Raise your hand if you or someone you know is gay, lesbian, bisexual, or transgender. And then raise your hand if you are prejudiced. And then raise your hand if you had someone close to you pass away within the past year. And then raise your hand if you could use a hug right now. All right. So this would be a great time for an open discussion, except we cannot do that, unfortunately, because of COVID and how that has changed the world as we know it. So we encourage you to use this time to reflect on this activity and note how you're feeling right now. Is there anything you want to say about why you raised your hand for a particular question? You can feel free to add that to the chat if you'd like. And then think about what was the purpose of this activity and what did you learn? Hopefully, this activity has helped you see how different we all are and take that into account next time we interact with one another.
I think it's important that we look at all of these things and be aware that we constantly learn and change. As that's what cultural competency is, always learning and changing. So, have we laughed at a joke before? Have we been uncomfortable and didn't know what to say? Those are important pieces to realize, and then say, what can I do next time that situation occurs? Right? That's how we build. That's how we move forward together. So, what can we do now? We can look at our internal programs and we can say, how can we be more culturally competent? How can we provide better sexual health care? So you could look at your website. Is your website clear and easy to navigate? Is it available in multiple languages? Can you develop brochures? Some people like written material. Not everybody loves to take that brochure off the shelf and take it home with them anymore, but some people do like written material. So have that available. Do you have a newsletter? Is it available via email, online? This group's newsletter is fantastic. The Rochester Sexual Health Task Force, fantastic. I love how bright and easy to read it is. Are people reading it? Are they getting it in the right method that they want? Is it available in print if they want it? Look at your social media messaging. These are quick things that you can change and you can make them more culturally competent. Is it pictures which are easy to read? Do people engage? Sexual health is a hard area, right? I'm going to put that as what it is. People aren't going to be like, yeah, I had an STD last week and I got treated by you and it was awesome. However, they might share their content with their friends. I know for our social media pages, when we posted an article about COVID-19, and if you were having sex with someone who you were not social distance with, you should wear a mask, right? That was one of the recommendations that came out. And we had lots of people sharing and commenting about that article. And that was a little bit more interactive, right? Look at how you ask questions. Are you trauma informed? So, trauma informed care is an approach in the human services field that assumes that an individual is more likely than not to have a history of trauma. And this recognizes that presence of trauma and the symptoms of what it could look like and acknowledges that it could play a role in someone's life, including the staff, right? So the staff may have their own trauma and they're trying to help someone through something similar, or maybe they're dealing with their own thing and we take that home with us. Be trauma informed, be aware. Increase your LGBTQ provider information. So, one of the biggest things that has stuck with me for a long time, I did a training a couple years ago about trans care, and they were talking about how this trans man went into a provider and was like, hey, I have a sore throat. And they were like, well, I can't help you. And he was like, why? And they were like, well, you're trans. And he was like, but I have a sore throat. That doesn't impact my sex or my sexuality or what gender I'm presenting as. I have a sore throat. Maybe that provider had some preconceived notion that that might be related to the type of sex that they were having. But if it's related to the type of sex that you're having and you're concerned about an oral sex transmission of, say, chlamydia or STIs or gonorrhea, you would treat them the same way as you treat anyone else. Just because someone is trans does not mean that they get a different outcome if they have a cold or a sore throat, right? Treat them as we would treat our patients. There are certain things for trans patients. Do you have a cervix? We might need to discuss you having a pap smear, even though that body part is something that you might not want to talk about. Look at your intake forms. Are your intake forms done in multiple languages? Are they easy to read? Are they confusing? I know that's something that we're constantly evaluating at our organization because you need certain data points, but you also want to make it easy for your patients to fill them out. Increase your language of neutral use for staff, right? So instead of asking someone, tell me about your boyfriend and girlfriend, you could say, tell me about your partner. Tell me about the sex of those that you, tell me about the genders of your partners, the sex of those that you have sex with. If I'm assuming that someone is heterosexual and I ask them about their boyfriend or girlfriend and they have sex with everyone and anyone, or they have sex with just one gender and it's not the one that I assumed, it's shutting down the care. It's not allowing me to provide quality care to them. And of course, get feedback from your community, good, bad, and everything in between. So that's why we talk about, even with this presentation, we use different sources. We're constantly learning and evolving. And the groups that we're working with may also vary. So always look to learn and grow together. So, big takeaway from today. We want you to understand that really one size care doesn't work. We can't assume that everyone needs that yearly physical and we're set. Why is that yearly physical important? Why is it important to see your doctor when you're not feeling well and when you're feeling well? Um, Understand that we will not know the needs of the communities that we serve unless we ask. So we want to make sure that we can actually take care of them. So COVID-19 opened a lot of those social determinants of health. People were saying, I'm going to lose my house. I don't have money to put food on the table this week. I don't have transportation. How can we serve those that we're working with? How can we get them condoms when they don't want to come into the health center? One thing that we did with our organization is we started mailing safe sex kits out that had external and internal condoms, dental dams, lubricants, instructions, and talked about the availability of our free education resources. Training is a must. Continuously train. That is how you grow and develop as a professional, as a human being. Continuously train. Never say, "Oh, I'm an expert and I'm great and I don't need more information." Always look to learn from others. And that training should involve many levels of staff. So from entry level to administrative, the people that you're working with, they're also training you. We're training them, they're training you. It's a give and take relationship. Cultural competency really it helps to make you a leader, promote mutual respect, and become more comfortable with our differences. It creates awareness of those differences too. Because here in the United States, I'm kind of getting away from this concept that we're a melting pot. A melting pot says that everyone gets in and we all melt together and we become this thing. We should look at it as a salad bowl. That's such a better expression, right? A salad bowl, everybody gets in, and the carrots and the and tomatoes and the cucumbers and the salt and the pepper, and they all bring these bold, vibrant pieces to the salad, and they complement each other. We can complement each other. We can work together, and we can use our differences to provide better care. Use our relationships to help connect people to services that are culturally competent, that are aware, and work together to really take care of our communities. So if we work with people from various backgrounds, if we take a minute to think before we speak and act, apologize when we've done something wrong, because ultimately you will make mistakes. We make mistakes every single day. That is in human nature. Sometimes we react a certain way and we didn't mean to, or our body language may have given something away. I know for me, I'm a very visual facial person. So sometimes I'll be like, oh no. Acknowledge that. Acknowledge the discomfort in sexual health care in itself. That topic in itself can be really difficult. And try to understand how we can better serve our patients and our communities where we are. So, this is our contact information. We really hope that you found this valuable today. You can reach out to us. That's our cell phone. You can text or call, and then our company email. Um, and we have a slide here with some sources as well. So thank you all so much. We will be around here in the chat, and you do have our contact information as well.